Today our topic of discussion is adrenal insufficiency. Adrenal insufficiency, okay? So we are approaching to the end of our curriculum, end of our syllabus by the third week of this month. এই কি কথা বলছো তুমি ওখানে? কি কথা বলছো? হ্যাঁ? কথা বলো না, শোনো। So after this class, probably the CRs has been communicated with Dr. Rajashri Bhattacharya to have a revision of practical slides in department. Right? So it is a very interesting topic, adrenal insufficiency, and a very vast topic too. But what is important, that is to conceptualize rather than to memorize. Okay. So adrenal insufficiency, the problem question may be asked in your exam in long answer format, long question answer format, 15 number marks, with a clinical presentation of the patient of acute or chronic adrenal insufficiency, or as a short note as Addison's disease or glucocorticoid replacement therapy, etc. So first, coming to the adrenal insufficiency, we have to know what is an adrenal gland. So we have two adrenal gland. Adrenal gland, the other name of adrenal glands are suprarenal. So it is very much evident from the name that the location of these two extremely small but extremely impactful glands are situated on the top pole of both the kidneys. So suprarenal, that is the superior aspect or the top aspect of the kidney or the renal parenchyma. So this is called as suprarenal glands. We have two adrenal glands, and coming to the anatomy or normal histology to adrenal gland, likewise kidney, adrenal gland has also three zones, okay, mainly two zones. One is cortex and another is medulla. For all the organs having medulla, likewise the medulla carries the vasculature, the vessels, the veins and the arteries, capillaries, etc. So cortex is the outer portion of the suprarenal gland and medulla is the central portion of the suprarenal gland. Medulla is responsible for secretion of two vasopressor, namely catecholamines, epinephrine and norepinephrine. And the cortex, the outer portion of the adrenal gland, that is the cortex, is again subdivided into three zones. Three zones to memorize a simple mnemonic, that is G, F and R. That is zona glomerulosa, zona fasciculata and zona reticularis. Okay. So zona glomerulosa is responsible for secretion of GM, general manager, that is mineralocorticoid. Okay. So the glomerulosa portion is responsible for secretion of mineralocorticoid. The fasciculata portion is responsible for secretion of glucocorticoid, and the reticularis, the innermost portion of the cortex, that is zona reticularis, is responsible for secretion of the sex steroids or the androgens. Okay. So it is very much evident that in case of adrenal insufficiency or any trauma, any tumor, any infection, any structural and functional disturbance to the organ is responsible for destruction of this secretory mechanism. As a result, this hormone secretion as well as their physiological effects will be lost. Okay. So coming to the concept that positive feedback and negative feedback, very much well known from the lower classes of science background students, that the hormones they exhibit are negative feedback. So this adrenal medulla is under direct supervision of pituitary gland, and the pituitary gland is direct supervision of hypothalamus. So any hormone of our body is controlled by three-tier system, three-tier office system. The head office is situated in the hypothalamus. The intermediate office is situated in pituitary, and the local office is situated in the target organ. Here the target organ is adrenal medulla. Okay. So any input of decreasing hormone production or increasing hormone production may give signal to the HPA axis, that is hypothalamus, pituitary and adrenal axis, and they function accordingly. If adrenal medulla or adrenal cortex is designed to secrete profuse hormones or increased hormone production, then the increased hormone production, that the increased input from the local office will send a negative feedback to the intermediate office in pituitary. So the pituitary will release less ACTH, that is adrenocorticotropic hormone. Less ACTH will be produced by the pituitary to make a homeostasis or equilibrium condition of the adrenal cortex and adrenal medulla. And if the pituitary insufficiency, as in case of secondary adrenal insufficiency, so the negative feedback will be sent to intermediate office to the ultimate head office hypothalamus. So the hypothalamus, according to the propensity of the signal getting from the pituitary and adrenal medulla, it will act accordingly by increasing or decreasing the hormone production. The name of the hormone is CRH, corticotrophin releasing hormone. Okay. So from this three-tier concept, okay, it is quite evident that adrenal insufficiency is classified into primary type, secondary type and tertiary type. What is primary type? Whenever the adrenal cortex and adrenal medulla as well the adrenal gland in total is affected. What is secondary insufficiency? That is, the problem lies within the pituitary gland, whether it is a tumor, whether it is a metastasis, whether it is apoplexy, whether it is an infection. Okay. And the tertiary adrenal insufficiency, it comes from the hypothalamus. So the hypothalamus will secrete very less CRH or corticotropin releasing hormone. So it is named as tertiary adrenal insufficiency. This concept need to be memorized, need to be conceptualized for the derivation of the classical signs and symptoms of adrenal insufficiency. Okay. So coming to the slides. So it is a life-threatening endocrine disorder. Why it is a life-threatening endocrine disorder? Because acute adrenal insufficiency is vastly responsible for sudden drastic decline in epinephrine or norepinephrine vasopressor level, glucocorticoid level, and it is life-threatening and as well as fatal, very high mortality rate if not corrected or managed in a very prompt way. So, adrenal insufficiency is a condition in which the adrenal glands fail to produce adequate amount of cortisol or aldosterone. So, types of insufficiency classified into primary, secondary and tertiary. I told you earlier, primary is also named as Addison's disease. It is a very important topic for short note. Secondary is pituitary dysfunction. I told you earlier, due to trauma, due to tumor, due to infection, due to apoplexy, and tertiary hypothalamic dysfunction, most commonly due to sudden steroid withdrawal. Okay, this is a global health concern. It is rare, but global health concern and clinical urgency, delayed diagnosis and treatment can lead to adrenal crisis, a medical emergency with high morbidity. Physiology of adrenal gland: adrenal cortex zone, zona glomerulosa is for aldosterone, zona fasciculata is for cortisol, zona reticularis is for androgens, adrenal medulla is for catecholamines, epinephrine and norepinephrine, which is crucial for stress response, and the HPA axis, that is hypothalamic-Pituitary-Adrenal axis, regulates cortisol production through corticotropin releasing hormone and adrenocorticotropic hormone signaling. So, negative feedback control of cortisol on hypothalamus and pituitary maintains the hormonal balance or homeostasis. Next, primary adrenal insufficiency, that is the disturbance or the pathology lies within the gland itself. So, what are the common etiology? Autoimmune, commonly that is named as Addison's disease, due to an antibody to the 21 hydroxylase enzyme. Infections due to TB, due to sarcoidosis, due to histoplasmosis, or metastasis from commonly from brain, commonly from breast and lungs. Okay. Secondary adrenal insufficiency caused by inadequate ACTH production due to pituitary disorder, that is tumor, namely craniopharyngioma, pituitary craniopharyngioma, trauma in brain in road traffic accident, and surgery in brain surgery due to accidental removal or disturbance of the pituitary gland. Tertiary adrenal insufficiency, when the head office is affected, that is hypothalamus is affected, and due to functionality affected due to suppressed hypothalamic CRH or corticotropin releasing hormone output, often from prolonged exogenous steroid therapy. So, often prolonged exogenous steroid therapy will be enough to create a constant negative feedback on pituitary as well as hypothalamus. So, the hypothalamus will be start losing its functionality, and the CRH production will be very less. So, it is quite important to distinguish between a registered medical practitioner with a quack practitioner, and try to avoid to ingest steroids for small disability, small duration illness, etc. So, steroid is often very much magical therapeutic drugs in short term, but in long term it is very much fatal due to constant pressure on the hypothalamus due to excessive negative feedbacks down the years. Okay. Differential diagnosis: primary includes mineralocorticoid deficiency and hyperpigmentation. Secondary, tertiary do not. So, that is the differential diagnosis, or that is the point of differentiation, whether the adrenal insufficiency is primary or adrenal insufficiency is secondary. Okay. So primary adrenal insufficiency will be affected by, the patient will be affected by hyperpigmentation due to ACTH driven melanocyte production or melanin production and mineralocorticoid deficiency, because pituitary and hypothalamus don't are not responsible directly for mineralocorticoid secretion. So mineralocorticoid deficiency, that is the symptoms of hypovolemia, hyponatremia and hyperkalemia, will be inevitably present in primary adrenal insufficiency, but surprisingly absent in secondary and tertiary insufficiency. Okay. Next. So etiology of Addison's disease, that is primary adrenal insufficiency origins. That is the most common in industrialized nations, autoimmune adrenalitis. That is autoimmune, that is antibody that is active or detrimental against body's own antigen or body's own enzyme. So the antibody here, the autoantibodies target 21 hydroxylase enzyme. Infections like tuberculosis, fungal infection, histoplasmosis, HIV, cytomegalovirus are also major infectious contributor to the primary adrenal insufficiency, that is Addison's disease. Genetic and congenital disorder include congenital adrenal hyperplasia and autoimmune polyglandular syndromes. Metastatic infiltration, secondary neoplasm, especially for lung and breast cancer, can destroy adrenal tissue. So Addison's disease is exclusively limited to the adrenal gland. Okay, student, huh? So Addison's disease or primary adrenal insufficiency is exclusively limited to the location of adrenal gland, not beyond that. Hello. So etiology of secondary and tertiary insufficiency, pituitary disorder, that is secondary adrenal insufficiency, and hypothalamic suppression, that is tertiary adrenal insufficiency. Pituitary disorders, tumor, surgery, radiation, apoplexy, or that means the congestion disrupting ACTH production, hallmark of secondary insufficiency. In postpartum patient, there will be pituitary apoplexy in some patients. Okay, then the patient will suffer from secondary adrenal insufficiency and very less ACTH production. Hypothalamic suppression, I told you earlier, for iatrogenic or exogenous long-standing steroid use. Suppress CRH and ACTH via negative feedback. Trauma and infiltrative disease, sarcoidosis, histiocytosis. Trauma can impair HPA axis regulation. Iatrogenic origins. Prolonged corticosteroid use is the leading cause of HPA axis suppression worldwide. So, as a medical student, you have a duty to inform your fellow colleagues and to inform your family members that injudicious use of steroids for short duration illness or for minor illness will cause more harm in long term than benefit. Okay? Next, pathophysiology of adrenal insufficiency. So hormonal disruption and systemic effect. So from the zones and from the hormones, it is very easy to derive the classical symptoms and signs of adrenal insufficiency. So glomerulosa, the mineralocorticoid, if the mineralocorticoid production zone, zona glomerulosa of adrenal cortex is harmed or affected, then the mineralocorticoid production will be less. And if mineralocorticoid production will be less, so mineralocorticoid is responsible for conserve the water volume, conserve the blood volume and the electrolyte balance. by taking the sodium inside the cell and expulsing out the potassium outside the cell. So the mineralocorticoid deficiency of adrenal insufficiency will have the symptoms of hypovolemia, hyponatremia and hyperkalemia. Okay, khub soja. Next come the glucocorticoid, that is the zona fasciculata. So the fasciculata region of cortex is affected. That means the cortisol production is low, the glucocorticoid production is low. So what will be the affected? Neoglucogenesis is affected. So the patient will experience hypoglycemia. Glucocorticoid is also responsible for making vascular tone. So body will experience fatigue, body will experience neuromuscular tingling and generalized weakness. So the glucocorticoid is an anabolic hormone. So if glucocorticoid is lost or in production, or glucocorticoid is very much less in production, then the anabolic property of individual will be lost, will be compromised. Okay, so hypoglycemia, generalized weakness, fatigue will be there. Immune modulation also be there, and inflammation due to cortisol deficiency. Next, HPA axis failure. Disruption or in CRH or ACTH secretion affect cortisol synthesis. Feedback loop is compromised, and systemic manifestations include hypotension, as cortisol is responsible for maintaining the vascular tone, hypoglycemia, myalgia, cognitive impairment and reflective multisystem impact. So it is very much easy to derive 5 to 6 signs and symptoms of adrenal insufficiency by memorizing the hormone name and memorizing the hormone functions. So fatigue and weakness, most common presentation. Cortisol deficiency, energy metabolism and neuromuscular function. Hypotension and dizziness due to reduced vascular tone and hypovolemia. Hyperpigmentation, I told you earlier, this is a very differentiating feature between primary and secondary and tertiary. The primary cases of adrenal insufficiency will have hyperpigmentation due to increased ACTH driven melanocyte production, okay, or melanocyte stimulation, that is increased melanin synthesis. Gastrointestinal disturbances, nausea, vomiting, abdominal pain and weight loss are frequently reported symptoms, okay. These are gastrointestinal disturbances. So very much important, diagnostic workup of adrenal insufficiency. So diagnostic workup is very much important to diagnose the condition. If diagnosed, then to differentiate between primary, secondary and tertiary. এই তুই কি করছিস লাস্টে? অনেকক্ষণ লিখছিলিস, তারপরে ফোন নিয়ে কি হিসাব করছিস? কিছু তো করছিস একটা, বল কি লিখছিলিস? পড়াশোনা করছিস? এখানে এসে বস, কত পিছনে দেখতে পাচ্ছিস? মিথ্যা কথা। আচ্ছা, তাহলে ডায়াগনস্টিক ওয়ার্কআপ কি আছে? বেসাল কর্টিসল মেজারমেন্ট। তাহলে কর্টিসল ইজ হাইয়েস্ট ইন magnitude in the morning time. So hormones have generally diurnal variation of production. So any hormone that will be different in magnitude, different in blood serum level in morning and in night, and cortisol has the maximum diurnal impact. So it is recommended that serum cortisol level measurement should be done in the morning, preferably 8 AM in the morning. So at that time the hypothalamus-pituitary and adrenal axis is in optimum functioning condition and the cortisol production and the response will be the maximum. So it is the basic measurement of cortisol, serum cortisol level is necessary at morning time to diagnose a adrenal insufficiency. So it is less than 140 nanomole per liter, 140 nanomole per liter or 5 microgram per liter. So basal cortisol measurement less than 140 nanomole per liter or 5 microgram per deciliter suggests insufficiency. Next, plasma ACTH level. So plasma ACTH level will be unaltered in primary, but it is decreased in secondary. Okay, so plasma ACTH level elevated in primary due to abolition of negative feedback, but it is suppressed in secondary and tertiary insufficiency. Guides the differential diagnosis. আচ্ছা, electrolyte panel করব কি? Hyponatremia, hyperkalemia and hypoglycemia. That supportive evidence of primary adrenal involvement. Imaging and antibody test, CT and MRI for structural causes, for diagnosis of tumor, for diagnosis of metastasis, for diagnosis of any necrosis or hemorrhage, structural damage to the glands will be diagnosed by imaging technique like CT scan or MRI, and 21 hydroxylase antibodies for autoimmune adrenalitis. So estimation of these autoantibody will be beneficial to deduce a autoimmune cause. এটা diagnostic workup হলো। এবার gold standard of examination কি? ACTH stimulation test. So ACTH stimulation test means ACTH, synthetic ACTH will be administered exogenously to check whether the adrenal cortex and the HPA axis are responsive or not. So purpose and timing preferred at 8 AM for accuracy, I told you earlier, the best optimum functioning of this axis, and it measures the adrenal response to synthetic ACTH or co-syntropin hormone. Procedure 250 microgram co-syntropin, that is synthetic ACTH, IV or IM, and serum cortisol measured at baseline, that is 0 minute, 30 minute and 60 minute. So it is expected that after administration of synthetic ACTH, the responsiveness of adrenal cortex will be increased and the cortisol production will be increased. But in case of insufficiency of primary and secondary, this ACTH stimulation will be lost. So the peak cortisol level will be less than 500 nanomole per liter at 30 to 60 minute intervals, confirm insufficiency. Okay, একটা আমরা দেখলাম কি ব্লাড কর্টিসল মেজার করলাম সকাল 8টার সময়, দেখলাম কম আছে, তার মানে অ্যাড্রিনাল ইনসাফিসিয়েন্সি হলো। আবার কি করলাম, বাইরে থেকে ACTH দিলাম সকাল 8টার সময়, তারপরেও দেখলাম ACTH এর পাওয়ার পরেও, ACTH এর অ্যাডমিনিস্ট্রেশনের পরেও কর্টিসল বাড়ছে না, মানে রেসপন্সিভনেসটাই লস হয়ে গেছে। তার মানে দ্যাট ইজ দ্য গোল্ড স্ট্যান্ডার্ড অফ ইনসাফিসিয়েন্সি, যে বাইরে থেকে আমি ACTH দিচ্ছি, কোসিনট্রপিন দিচ্ছি, তা সত্ত্বেও আমার কর্টিসলের যেটা পিক রাইজ হওয়ার কথা এক্সপেক্টেড, যেটা 500 ওপরে ন্যানোমোল পার লিটার হওয়ার কথা বেশি, সেটা আমার পাচ্ছি না, তার কম হচ্ছে, তাহলে দ্যাট ইনক্লুডস দ্য ইনসাফিসিয়েন্সি। সো লিমিটেশন কি? লিমিটেশন হচ্ছে রিসেন্ট অনসেট সেকেন্ডারি ইনসাফিসিয়েন্সি ডিউ টু প্রিজার্ভড অ্যাড্রিনাল রেসপন্সিভনেস। So it may miss because the secondary insufficiency, very recent onset or hyperacute cases of secondary insufficiency will have the residual adrenal cortex responsiveness preserved, so that the ACTH stimulation test may miss. But this is ACTH stimulation test is gold standard for diagnostic adrenal insufficiency, and timing of the tests are 8 a.m. in the morning for both cortisol measurement and ACTH stimulation test. So imaging and biomarkers, CT and MRI of the adrenal used to identify hemorrhage, metastasis, calcification or infections. Pituitary MRI, essential in secondary or tertiary forms to detect adenoma and structural hypothalamic lesion. So structural কোনো abnormality থাকলে তাহলে ছবি তুলতে হবে। যদি প্রাইমারি অ্যাড্রিনাল ইনসাফিসিয়েন্সি আছে কিনা দেখি তাহলে পেটের ছবি তুলবো to get an image of suprarenal region. CT or MRI, USG may miss because it is very small and often suprarenal position will be marked by the renal cortex. So CT and MRI will be precise information it will give. আর যদি সেকেন্ডারি আর টার্সিয়ারি ইনসাফিসিয়েন্সি সাসপেক্ট করি তাহলে সিটি স্ক্যান এন্ড এমআরআই অফ দ্য ব্রেন ফর এনি স্ট্রাকচারাল ড্যামেজ or the infective changes of the pituitary and hypothalamus, okay, or tumor. Autoantibody testing, estimation of autoantibodies against the 21 hydroxylase enzyme to rule out autoimmune Addison's disease, and genetic screening for autoimmune polyendocrine syndromes considered in early onset of syndromic cases. These are genetic screening in rare variants of adrenal insufficiency that runs vertically, autosomal recessive fashion. So, genetic screening are important for hereditary cases. So now coming to the management, acute adrenal crisis is most important to manage, as if the physician miss the golden hour, the patient may lose. Okay, so acute adrenal insufficiency will be managed and addressed promptly before anything else. IV, preferably IV, and IM hydrocortisone. Because hydrocortisone has the very less short half-life, so it will start acting very rapidly than any other hormones. So precipitating factor is infection, surgery, trauma, abrupt steroid withdrawal in undiagnosed undertreated patient. Immediate management ki korbo? IV hydrocortisone 100 mg bolus, fluid resuscitation with isotonic saline for managing hypovolemia and correction of hypoglycemia. Clinical signs অনেকবার বলেছি, hypotension, vomiting, hypoglycemia, electrolyte imbalance and altered sensorium. Prognosis and prevention, delayed treatment can be fatal. Our chronic management strategy অনেক helpful, অনেক easier to manage, because chronicity in any hormonal imbalance might not affect your life in a very short manner. It may affect your physical quality of life, but it may not take your life until it is predisposed with an acute crisis. Okay, so chronic therapy, replacement therapy will be supported by prednisolone, that is glucocorticoid or cortisol, hydrocortisone or prednisolone in 2 to 3 divided dose, mineralocorticoid supplementation, that is fluorocortisone for primary insufficiency, maintain sodium balance and blood pressure, stress dosing protocol. So in any kind of stress, any kind of sickness, any kind of surgery, any kind of trauma, these are the common scenarios where the cortisol production will be lessened. So for the patients of cortisol replacement therapy for chronic insufficiency will be given much more higher dose in times of stress, in times of illness or surgery or trauma. Okay, regular monitoring of the clinical symptoms, hormone level, electrolyte panel and blood pressure monitoring. So glucocorticoid replacement therapy, prednisolone, dexamethasone, hydrocortisone regimen, modified release formulation, এগুলো দরকার নেই, খালি এইটা এই যে androgen replacement, DH EA replacement, dihydroethanyl androgen, considered in women with persistent fatigue, mood or libido issues despite optimal glucocorticoid therapy. Fluorocortisone used for mineralocorticoid depletion or fluid retention, sodium retention and potassium excretion. Okay. Symptom assessment, monitoring and dose adjustment, avoiding over replacement. So over replacement or over correction is not recommended. Biochemical monitoring in intermittent interval, serum sodium, serum potassium, glucose and morning cortisol level. And what is important? That is sick day rules. That is important for cortisol therapy. For chronic insufficiency patient, double or triple usual glucocorticoid dose during febrile illness, vomiting or surgery. And medical alert and IDs in case of chronic insufficiency patient or genetic cases of adrenal insufficiency or autoimmune insufficiency to make a triage that if anything acute emergency occur, the physician will recognize it from the batch and promptly inject hydrocortisone to the patient for saving his or her life. Family or caregiver education is also important. Thank you so much. So, it is important to memorize and conceptualize the hormones, their functions. If you know the hormones with their respective functions, it will be not tiring to derive 5 to 6 clinical signs, 5 to 6 clinical symptoms and 2 to 3 management pharmaceutical agents write down for you in exams.